Good evening. I'm Mike Slowey, one of the co-founders of Coastal Fertility Specialists, and tonight we're going to talk to you about fibroids and infertility. Now, to get started, one of the things I'd like to remind you is that we're going to have an opportunity for you to ask questions, but I'm going to take all the questions at the end. It's just a little bit simpler because if we go through, a lot of your questions may get answered by the time we get through all this, okay? So my goal is to talk for about 15 to 20 minutes, which for those of you that know me might find that an impossible task, but we'll see how we do, okay? And then we'll take questions and go from there. I hope you guys have sunshine. We had a lot of rain this morning. I'm in my office. It looks a lot brighter now at 6 in the evening than it did at 8 in the morning. It looked like midnight this morning. So let's get going. What are fibroids? You hear that a lot, but what are they? So the medical term for them is leiomyoma. Easy for me to say, right? That's why we call them fibroids. They are benign tumors of the uterus. The uterus consists primarily of smooth muscle with our thin lining on the inside. And so these are cells that start dividing abnormally and then grow to a little ball, and sometimes they can grow into bigger balls and into really, really big balls, okay? They are benign. They are not cancer. Now, there is a smooth muscle cancer of the uterus, and it's called a leiomyosarcoma. They're actually quite rare. I've been doing this for over 30 years now, and I have done hundreds of fibroid surgeries, and I have yet to come across a leiomyosarcoma. My co-founding partner, Dr. Schnorr, has also done tons of myomectomies, and he's only run across one. So they're very, very uncommon, but certainly they're very serious. And always when fibroids come out, which we'll get to later, they're always going to the pathologist to check and make sure. But generally speaking, when we're looking at fibroids, we're not looking at cancer. So the next thing that we do is we're going to talk about how do we diagnose them. Well, many times we're able to diagnose them on exam because the uterus grows and you can actually feel it on exam. And the uterus, instead of being a nice little firm pear-shaped organ, can start to feel lumpy bumpy because of the fibroids growing on it. And it can grow. Normally your uterus is about the size of your fist, and it sits low in the pelvis. But sometimes with these fibroids and the way they grow, you can feel them above the pubic bone, above your belly button, and in rare cases, they can get up and make it difficult to breathe. Unfortunately, those are very rare. But you can feel them on exam. And then, of course, we have our radiologic techniques. Ultrasound's most commonly what we use and we find them. But our x-ray tests, the HSG, we can find that. The saline sonography, which is where we're putting liquid inside the uterus, and we're using ultrasound, we can see it there. And of course, MRIs and CT scans can find it as well. And then finally, of course, you run into them at surgery. You may be doing something else and you see some fibroids there. But most of the time, they're either being picked up by exam or most of the time ultrasound with us, okay? All right, now let's start with what's normal. What does a uterus look like? Uterus looks like a pear, and holding it upside down. And like I said, it's about the size of your fist. It primarily consists of smooth muscle and has the fallopian tubes coming off the top ends of it. The inside of the uterus, the endometrial cavity, has the lining of the uterus, which is where the embryo will ultimately try to implant. And this is what we call a theoretical space. When you see it in a drawing, it looks like this big triangular area, but in fact, it's just the space between my hands here, right? Like that. That's a theoretical space. And when we open it up with fluid, then you can see, yes, there's an area in there. As you would expect, the lining of the uterus has a very, very robust blood supply, and that's going to be a key to talking about fibroids and how they cause problems. So here is a laparoscopic image of a normal uterus. So here's the uterus right here. This is the very top. The cervix and the vagina are away, and as we go up, we can see a fallopian tube and an ovary, and then we have the other fallopian tube and ovary there. But this is a normal looking uterus. Now, fibroids can be in a number of locations, and what that does for us is it can create problems with the circulation. We'll get to that in a second. So now we have a nice little drawing of the uterus. And as you can see, I have a nice superficial fibroid. Okay, we tend not to worry too much about those. And then we have one that's a little bit less superficial, one that's in the muscle, but it's very small. Now we have two that are altering the cavity. So we're going to talk about those in particular because those are oftentimes a problem. Then, how do they cause problems? Well, the size of the fibroid can obviously be a problem. The number of them can be a problem, and that's always a wild card. But I like to think of them like real estate. Location, location, location. And if you don't hear anything else I say in the next few minutes, fibroids that alter the lining of the uterus are going to be a problem, and the majority of the other ones are not. Okay? But that's not an absolute truth. Like I said, it's a majority, but not all of them. So this is a really fun drawing that was from a paper written by a friend of mine, actually, in 1981. So here's kind of the general drawing of the uterus, kind of very similar to the one we just looked at, with the different locations. But the key here is the circulation. The circulation of the uterus comes in at this level and then goes up the outside, okay? And you can see it in this cross section here. It's along the outside, and then it has to penetrate. Well, you can imagine that fibroids here and here are blocking the blood supply from getting the lining. So you can see here, this blood vessel, the main blood vessel coming here, and then look how it's getting disrupted from getting all the way down to the lining. And you can get pooling of the blood supply, and so you don't get good oxygen delivery and nutrient delivery to the lining of the uterus. So that's a major mechanism. Another major mechanism by how they cause problems, these are just not little rubber balls. They actually feel like balls. You guys all play jacks? They feel like those rubber balls, except they don't bounce as well. We won't talk about why Dr. Slowey knows that. But anyways, they alter the circulation, but they secrete growth factors and hormones, and that can create problems as well. But I love this picture. It does a really nice job of showing the altered circulation that we have to the lining. All right. So what types of problems can we have? Women can have symptoms from their fibroids. Of course, it can create a problem getting pregnant, maybe contribute to pregnancy losses, and then in pregnancy there can be problems. So let's go through theirs. Now, many of the symptoms are related to other structures that the fibroids can impact. So they can create pelvic pressure because fibroids are way like a baseball or a softball. And so that can create fullness. You can create problems with pressure on the bladder, so you have to go to the bathroom a lot. You can create problems on the rectum, so it can be constipated or really even obstructed. And then at least a third of the women will have problems with menstrual disorders. They can have prolonged bleeding, they can have heavy bleeding, and they can get to a point where they can be anemic. I've certainly seen women where the fibroids have been allowed to grow to a long time that they are so anemic, you actually have to transfuse them before they do surgery. And in a day gone by, before surgery, you get into the 1800s, most major surgeries that we do now got their start in the late 1800s, 1880s, 1890s. Times before that, women would die from basically bleeding to death. That can be an issue, okay? So those are the symptoms. So that's when we say somebody's symptomatic, those are things that we're looking for. How do they cause infertility problems? Well, one probably obvious one is when you look at those pictures I was showing you, they can actually just outright block the tubes. The opening of the fallopian tubes very, very tiny, just about like the head of the pin, and it doesn't take much to plug that up. So just pressure of the muscle on the opening of the tubes can create problems. Number two, as the uterus grows with fibroids, that can start to take the fallopian tubes away from the ovaries, so it can have a more difficult time picking up the egg. And then you get into the issues of the uterus itself. It can alter the location of the cervix in the vagina, so it can get pulled up as the fibroid gets big, so it's harder for the sperm to get in. Mucus secretion may be altered. And then, as I was mentioning, it distorts the lining of the uterus, makes it harder for the sperm to travel through, make it more difficult for an embryo to find a suitable place to implant. The uterine muscle can be disrupted and how it contracts. That contributes to the problems with bleeding, okay? Because it's uterine muscles that stop bleeding when we have our period. And if think about this, how would it hurt, or why does it hurt? Think about having a golf ball or a tennis ball in the middle of your calf. And how would that feel trying to walk with that mass in there? Well, that's what your uterus is having to deal with when you have a fibroid in there. So you get dysfunctional contraction. And of course you have the altered blood supply, which can limit embryonic growth, cause abnormal development of the lining of the uterus. You can actually get an inflammatory process, okay? So these are all ways that fibroids can contribute, and this is all structural, to difficulty getting pregnant. As far as miscarriages, I think most of us believe that they can contribute to them. It can create a problem where the implantation is not as ideal. There can be an inflammatory process. Usually that's going to prevent getting pregnant to begin with. And there can be compressive effects just from the mass effect. And miscarriage rates can be elevated, 40 to 50 to 75% in women with fibroids. And our general population miscarriage risk is 15%. So clearly they can cause an impact, but again, it's not going to be in everybody. So, and then finally, in terms of pregnancy-related problems, it has to do with how the uterus works in pregnancy. You can get irritability because of the fibroids in the muscle, so you can get preterm labor. They can be a mass effect. They can block labor. Big enough fibroid can make it hard for a baby's head to get out. You can cause malpresentation, so breech presentations. There's not enough room for the baby to turn around. Depending where the placenta is, maybe it couldn't implant as well, and so they're more likely to separate. It's called a placental abruption. The uterus, because of the dysfunctional contractions, can be more likely to not be able to clamp down after delivery, so you can get bleeding afterwards. And then, of course, you can have problems with the placenta getting actually stuck in there because it invaded too far. And then, just because of the fibroids, oftentimes they can degenerate, it can cause pain. Now, just because there's a little tiny fibroid in there doesn't mean you shouldn't become pregnant, doesn't mean we should go after it surgically. In pregnancy, studies clearly show most fibroids don't do anything, okay? And the symptoms that we're talking about there are related to what their size was to begin with. Of the fibroids that change in pregnancy, most shrink. Fibroids growing in pregnancy are extremely rare, okay? So just because you have a couple little fibroids in there, I wouldn't want you to worry about that. Again, if we're seeing fibroids and we want you to worry, we'll tell you to worry, and we'll be doing something about it too, okay? All right. So, I have my little slideshow actually right behind the screen here, and I'm going the wrong way with it. So much for the secrets here from the Wizard of Oz. All right. So, it's an argument by a lot of people that say maybe fibroids don't cause a problem. I disagree with that. I very much think they do. But not every fibroid does. It goes back to what I said a while ago. Size, number, location, particularly location. Now, what makes this complicated is that the literature on this is very diverse. And it's problematic because everybody's fibroids are different. The number of fibroids are different, the sizes of them are different, the location are different, and the combinations of different sizes and location are different. So it's very difficult to, there we are, we're back. It's very difficult to design appropriate studies to look at these. But when we look at the data that are out there, and again, most of them are small, the control groups are very difficult, if non-existent, and a lot of them don't do a good job of characterizing the fibroids. So if you look at people who have fibroids and you follow them just naturally, most studies show a lower pregnancy rate and an increased miscarriage rate. And again, most of these people have fairly significant fibroids that are in these studies. When you look at in vitro fertilization, the overall impression is that the pregnancy rates appear to be lower, but again, depends on the size and location. And when you're looking at the fibroids for women who are not symptomatic, and the fibroids are buried in the uterus, but they don't alter the cavity, the data are very much conflicting, although I think most of us would believe that if a fibroid's big enough, you get in the 4 or 5 centimeter range, it can possibly play a role. And all the study issues for all of these are in play all the time. So it's been a very difficult area to study. So none of this is rocket science. So in terms of women with fibroids, who needs treatments? Well, the easy one are women who are symptomatic, okay? You're having problems with bleeding, you're becoming anemic, you're having significant pain, you're having to go to the bathroom all the time, or you're constipated and you look at the fibroids and there they are, they're in the area that would be causing the problem. You know what? Treating the fibroids can work really good for you. Women who are having fertility issues, and we have fibroids that alter the cavity, pretty much everybody in our field believes that you're better off without them. And then finally, we have the ones that are superficial. The only time you really need to go after those is if there's symptomatic, and usually those are pretty big ones that you have to go after there. Now, the ones that I'm going to talk about for a little bit are the ones I just kind of mentioned, the ones that are in the muscle, but they don't alter the cavity. And there's a lot of literature on it, but again, it is very mixed. And again, overall, the impression is when they get to a certain size, roughly in that 4 or 5 plus centimeter range, most studies, and they've involved in vitro fertilization, show a lower pregnancy rate with those, so you probably are better off. But again, there's always needs to be a balance. Our treatment options for fibroids are 1, no treatment, like for anything we do. Yeah, no treatment's always an option. Medical treatments, surgical treatments, and then there are radiologic treatments. I will briefly touch on the medical treatments. The main ones are GnRH analogs, like Lupron or Lysum, the GnRH agonists and antagonists. And what they do is they shut the pituitary down, which in turn shuts the ovaries down, which shuts off estrogen, which is really important for the fibroids to maintain themselves, and they will shrink. But as soon as you stop those medicines, they will regrow. So they are a temporizing measure. Maybe that I've got somebody that's near menopause and we don't want to have surgery. Maybe we've got somebody that's bleeding and can't have surgery. They have medical conditions where you don't do it. Then you're using GnRH analogs. Sometimes you'll use them preoperatively, especially somebody that's got a really, really big uterus. You're trying to shrink it to make it a little bit easier surgery. That's really the times. RU486, the progesterone antagonist, does a pretty good job of shrinking fibroids as well. But once again, it's not permanent. So we don't have a medical treatment that is permanent. The surgical treatments involve what's called myomectomy. Myomectomy means remove fibroid, leave uterus, as opposed to hysterectomy, which means remove uterus. And that would take the fibroids with it. But around here, we have things to do with the uterus, so we like to leave them where they are. So we just try to tune them up by getting the fibroids out. Now, we have several approaches for doing myomectomies. For fibroids that are just inside the uterine cavity and altering the cavity, we have what's called hysteroscopy, where we put a scope inside the uterus, and then with various devices you can scrape them out or kind of gobble them up and get them out. Then there are the minimally invasive techniques, laparoscopy and robotic surgery. Those procedures are good for more superficial fibroids that are maybe symptomatic. The real trick with those is closing the uterus. The robotic surgeons can do a really, really good job of that because of the instrumentation. But you'd need to use a delicate closure to prevent scar tissue formation, and I think particularly the robotic does a very good job of that. But the problem is you lose your sense of feel. And a lot of times we're in surgically, yeah, we've seen a bunch on ultrasound, but you feel more of them. You feel like that golf ball in your calf. you actually can feel them, and you don't have that sense of feel with the minimally invasive techniques. So sometimes you can miss very important fibroids. For example, one that's directly underneath the lining that you can't see, and if you don't have that sense of feel, you're going to miss it, unless you know it's there and you need to go look for it. And then finally we have the true tested abdominal myomectomy or laparotomy, open procedure. And generally that's what we use for the bigger procedures. For the ones that are where they're up having a hard time breathing, there wouldn't be room to get the robot or laparoscope in there. You got to open folks up and go in. And some of them, because of their location, you're probably better off with an open procedure. But those are all the approaches that you can do. Now, over the past probably 20 years or so, there have been some radiologic approaches to dealing with fibroids. The one that is most widely used is uterine artery embolization. And so what they do is the radiologists put a little catheter in the groin, and they run it up the blood vessels, and then they will get the little catheter to the uterine arteries, and they'll put little pellets in there and block off the blood supply, because the fibroid's blood supply is a lot more tenuous, and that basically can kill and shrink the fibroids. But we don't like that procedure for women who are trying to get pregnant, because there's a fair number of complications that can come from it, such as 5 to 10% of the time killing the entire uterus and needing an emergency hysterectomy, 5 to 10% of the time having what we call collateral circulation take the beads to the ovaries and impacting ovarian function. On top of it, the data is pretty clear that pregnancies after a uterine artery embolization can be adventurous. Plus, they're just simply not that common. Now, part of that's because most of the time, these are older patients who have usually completed their childbearing. And so that's probably the patient that's ideal for uterine artery embolization. It is less invasive, but there's a variety of pros and cons I can talk about later with UAEs. There's also now some ultrasound-focused techniques that can be used by the radiologist or used at laparoscopy. The problem with that is basically it's killing the fibroid, and you get what's called liquefaction necrosis. It turns into a liquid ball. That's probably not a really good idea for a pregnancy to just have a ball of liquid in the uterus, because again, you still have a mass effect that's there. But it's a new enough technique. There is not very much literature on that, and I would certainly not something I'd recommend until there's better literature that talks about its safety. But no, those other techniques are out there. And again, I think there are things that can be used in the right situation, but most of the time, that's not for our folks that are trying to get pregnant. Let's see, going the wrong way again here. All right. Now, in terms of the ones that are buried in the muscle, the best way to look at it, in my view, because there just are no good controlled studies, is we say, all right, how are they doing after surgery? And you compare it to unexplained infertility. Now, unexplained infertility are our patients who have been trying to get pregnant, normal semen analysis, normal X-ray test, HSG, normal ovarian function. But so nothing obviously is wrong. About a third of them will get pregnant over 3 years without any treatment. But in the patients where you have fibroids and then you remove the fibroids, it's anywhere from 45 to 65% will get pregnant in 2 years after the procedure. So if the fibroids really were not having any effect, you'd probably see a pregnancy rate very similar to the unexplained infertility group. So that does suggest that the fibroids provide some advantage. But a disadvantage of the surgery is scar tissue formation, particularly the open surgeries that I tend to do. And even though we use microsurgical techniques, as all this gray hair shows, I'm from an era that we learned microsurgery. Even under the best of things, fibroid surgery causes scarring, which can alter relationships between the tubes and the ovaries. Sometimes you can get intestines involved, and you can get symptoms from that. So you have to be very careful, and that's why we don't do surgery willy-nilly for these things, because there can be problems from it. The studies that are available also suggest a loss risk that is markedly reduced. typically we'll see fibroid loss risk women prior to surgery in the 50-60% range. And again, baseline is typically about 15%. And it's usually reduced into the 20-25% range afterwards. Again, these are not controlled studies, but they give us a hint that maybe there is some benefit. But again, it's about patient selection, and each time you're looking at a patient, you are looking at the size and number of those fibroids to say, are these really causing the problem that we're dealing with? So overall, and one thing I almost forgot, is that fibroids can regrow. And they actually don't regrow, because the ones we took out belong to the pathologist. You grow new ones. My patients with fibroids have the God-given gift of growing them. It's a genetic thing. You can grow them. Now, the likelihood of somebody getting another fibroid surgery really depends on the number and size that you have, and also how old they are. If you're 40 years old and we have 3 or 4 fibroids that were modest size, the likelihood of you needing surgery again before you go through menopause and then they would shrink is going to be very small. But if you're 25 years old and I just took out 25 fibroids, you actually have a really good shot of having at least one more surgery for fibroids during your life. So if you look at the data overall, it's about a quarter of the women who undergo a myomectomy will get repeat surgery. But again, it depends: age, number, location, size. Okay, so we have that. So that's what I've got on fibroids for right now. And that's my little brief overview. I hope your head's not spinning too bad. But I'll leave you before you go to the questions with this. This is what a fibroid in the uterus can look like. This big lump right here is a big fibroid, and we have all these little fun things hanging off the sides, which looks very different than this, right? And again, this one right here is about 1/4 the size of this one here, just to give you an idea of the size-wise. Okay? All right. Questions?
Okay, we just have one.
All right.
Hi, Dr. Slowey. I'm feeling some pain in my lower abdomen from time to time. I've had miscarriages, and when I was a teenager, I had excruciating pains for my period. What should I do?
Okay. So were you guys able to, are they able to hear that or read that?
Potentially, if she's still on.
Okay. So we had a young woman that's had pain from a young age. She's had miscarriages. Mm-hmm. And the combination of the pain, certainly fibroids, could be present, but that's actually a pretty easy solution. You get to your gynecologist and get evaluated, combination of exam, and chances are, especially talking about the pain, getting an ultrasound would be a good idea to look at the uterus. Do we have fibroids? What about the shape of the uterus? Are there any ovarian issues that could cause pain as well? And certainly miscarriages, if you have multiple miscarriages, there's a very specific evaluation that we do to look at that. Now, most miscarriages are because an embryo is abnormal and they're random errors. And at a certain point, though, it stops becoming random. When you start collecting the miscarriages, there's a good chance it may not be random. So we look at the anatomy of the uterus. We're looking for fibroids, birth defects of the uterus, look at the genetics of the parents, look at the hormonal environment. There's a few things that can be a problem there. And then there's some antibodies that we look at from the immune system that can create problems as well. So those would be things to take up with your gynecologist. Okay?
Okay, she was able to hear you, so that's great.
Okay, good.
And then we've got one more that just came in from Samantha. What exactly are fibroids and what makes them develop? I'm still trying to wrap my brain around it.
Okay.
So maybe like the...
Okay, Samantha. So again, fibroids are derived from the smooth muscle of the uterus. So again, the uterus is mostly muscle. I've got my fist, that my uterus is about that size, probably about 90% of it's muscle, okay? And what happens, a single cell, something happens in its DNA, and it starts to divide abnormally. And it goes from 1 cell to 2 cell to 4 cell to 8 cell to 64 cells, and just exponentially going on up. And exponentially, that's all I could remember, by the way. I was not a math major, okay? And so all of a sudden, then it starts growing, and you develop a little ball. They do tend to be circular in size. Matter of fact, Here's a nice collection from one of my surgeries. Okay. This one's about 5 centimeters in size. Okay. All right. So they develop into these little balls. But they are, if you look at them under a microscope, they're muscle. They're muscle tumors. So they're masses. So they're muscle. But they're benign. They are not cancer. All right? They are not cancer. There are muscle cancers, leiomyosarcomas, but they're very rare. So Samantha, I hope that answered your question.
I think it did. Sharita says hi, and then Tina says thank you for doing this lecture.
Okay, well, thank you very much. All right. Are we all good?
Yeah, I think we're good.
All right.
Saying thank you.
Well,
So-
thank you all very much for joining us tonight. I hope this was helpful. Next month is Polycystic Ovary Syndrome Awareness Month. PCOS is an interesting metabolic disorder. My founding partner, Dr. Schnorr, is going to talk about PCOS on September 27th, right in this 6 p.m. time slot. So John will do a great job talking with you, and I hope you come back to listen to what he has to say. But thank you all very much for your time, and I hope you have a great holiday weekend coming up. Bye-bye.